بسم الله الحمد لله والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم. Inshallah, today we will start the pharmacology of the gastrointestinal tract, the GIT. Inshallah, in these two lectures, we will talk about the drugs that used for treatment of peptic ulcer and reflux esophagitis. Then we'll talk about the drugs that used for treatment of constipation, laxative drug, and drugs that used for treatment of diarrhea, antidiarrheal drugs. And last, we'll talk about the antiemetic drugs. As you know that the main function of the GIT is digestion and absorption of food. This is also beside that the GIT is the one of the major endocrine systems in the body, because GIT can secrete a group of hormones such that secreted by enteroendocrine cells in the stomach, such as secretin, which is a hormone that responsible for water hemostasis, also called cytokinin, the hormone that is stimulated or secreted by the GIT cells, and is responsible for the digestion of the fats and proteins. Functions of the GIT that important from the viewpoint of pharmacological intervention are: first, the gastric acid secretion, because hypersecretion of the gastric acid, this can result in peptic ulcer or duodenal ulcer. Also, the vomiting, the act of vomiting or emesis. Also, this can be either a physiological protective mechanism or sometimes arise as a symptom of disease or disorders, and sometimes as side effects or adverse effects due to the administration of drugs. Also, sometimes this is maybe needed to be treated pharmacologically by antiemetic drugs. Also, the third function of the GIT, the motility of the GIT and exclusion of feces. This is also important from a viewpoint of pharmacological intervention, because in case of accelerated motility, this can lead to diarrhea, and this can be treated by antidiarrheal drugs. And also the slowing or the decrease in the motility of the GIT can result in constipation, kinesis, or decreased movement of the GIT can result in constipation, and also this can be treated pharmacologically by the laxative drugs that used for treatment of constipation. Also, the formation and excretion of bile. This is also one of the points that we can intervene pharmacologically, such as in case of slow movement or slow flow of the bile, slow bile flow, such as cholestasis. This can result and can be treated pharmacologically. Can result from disease and many situations, and this can lead to symptoms in the patient, and this can be treated pharmacologically. Also, the formation of the gallstone. The gallstone also can be treated pharmacologically. So first, we'll start with the gastric acid secretion. The gastric acid secretion, which occurs by the gastric parietal cells, involves three carrier molecules. The first one is the hydrogen potassium ATPase. This is the gastric lumen. This is a parietal cell, and this is a plasma, the blood vessels, and this is right. First, we have proton pump, which, as I mentioned, hydrogen potassium ATPase. That pump ATPase means against the concentration gradient, so it need energy. It pump out the hydrogen and lead to the entrance of the potassium against the concentration gradient, because of potassium inside the cell is more than that is concentration outside the cell. So this is ATPase, need a carrier to pump. This is hydrogen potassium ATPase. The second molecule is potassium chloride semi-port. Semi-port يترافقوا مع بعض. This is without the need of energy, because this is directly with the concentration gradient, potassium outside and chloride outside, from the cell to the lumen. This is called potassium chloride semi-port. This is the second carrier molecule. And here the chloride with the hydrogen lead to the HCl, which is the gastric acid. The third carrier involved in this gastric acid secretion is called bicarbonate chloride antiport. Bicarbonate chloride antiport. Antiport because it lead to the secretion of bicarbonate in the plasma, and the entrance of chloride from the plasma to the gastric parietal cell. Then the chloride will flow out to the lumen through the potassium chloride semi-port. Now, where is the bicarbonate came from? The bicarbonate came from the carbonic acid, and the carbonic acid is formed from the carbon dioxide with water. Carbon dioxide comes from the plasma, and because it is lipid soluble, enter the cell membrane. Then the carbon dioxide with water, by the catalyst of the enzyme called carbonic anhydrase, lead to the formation of the carbonic acid. And the carbonic acid will deassociate deassociate عشان ما يديني هيدروجين ايون with البايكربونات. احنا الان عرفنا المصدر بتاع البايكربونات مع الهيدروجين ايون. نكرر تاني، قلنا هم جايات من الكربونيك اسيد. والكربونيك اسيد جاي من وين؟ جاي من الكربون دايوكسيد مع الووتر inside the gastric parietal cell by the catalyst of the enzyme called carbonic anhydrase, lead to formation of the carbonic acid, and the carbonic acid will deassociate to the bicarbonate molecule and hydrogen ion. Then the hydrogen will be secreted into the lumen, into the gastric lumen through the hydrogen potassium ATPase. Secretion of the as I mentioned, the secretion of the hydrochloric acid by the gastric cell involve, as I mentioned, a proton pump, which is an hydrogen potassium ATPase, a semi-port carrier, which is an potassium chloride semi-port carrier, and the last antiport carrier, which exchange chloride with bicarbonate. Bicarbonate outside to the plasma, and chloride inside to the gastric parietal cell. Carbonic acid, as we mentioned, catalyzes the combination of carbon dioxide and water to give the carbonic acid, which deassociate to form the hydrogen ion and the bicarbonate. What are the principal stimuli that act on the gastric parietal cell? We have three main principal stimuli that can stimulate the gastric acid secretion, which are: first, the gastrin, and the gastrin is an stimulating hormone that is secreted by the gastric itself and the duodenum, part of the duodenum, and secreted on, because it is a hormone, so it's secreted on the blood and circulated with the blood and came to the gastric parietal cell to stimulate through the gastrin receptor, stimulate the HCl secretion. Also, we have acetylcholine, which is a neurotransmitter that came from the cholinergic neurons that innervate the gastric wall. So the acetylcholine will act on the muscarinic receptor, as we mentioned before, exactly M1 receptor on the gastric parietal cell to stimulate the HCl secretion. The last is the histamine, which is a local hormone that's secreted by the mast cell nearby the gastric parietal cells, act on the H2 receptor, the histamine H2 receptor on the gastric parietal cell to stimulate the HCl secretion. While we have the prostaglandins, such as prostaglandin E2 and prostaglandin I2, inhibit the gastric acid secretion. Prostaglandin also an autocoid just secreted from the nearby cells that inhibit the HCl secretion and stimulate the mucus and bicarbonate formation. First, gastrin. As we mentioned, gastrin is the peptidic hormone that synthesizes in the endocrine cells of the mucosa of the gastric antrum and duodenum and secreted into the portal plug. And its main function and its main action of the gastrin is to stimulate the secretion of the gastric acid by the parietal cells through the gastrin receptors. We have a drug that called broglamide, which is an gastrin receptor blocker that inhibits the gastrin action, so it inhibits the HCl secretion, so it can be used in the cases of that there is an hyper secretion of the HCl or in case of peptic ulcer. Then acetylcholine and histamine. How do we know that acetylcholine, by acting on the M1 receptors on the parietal cells, it stimulates the gastric acid secretion, so that we have pyrinzabine, which we mentioned this drug before, and a selective M1 antagonist can be used for treatment of peptic ulcer. While the histamine, which as we mentioned, that's secreted from the mast cells, which lying close to the gastric parietal cells. Autocoid means local hormone, so it's close to the parietal cells. It stimulates the gastric acid secretion through H2 receptors, histamine H2 receptors. We in this picture we find this is gastrin, which is a hormone come from the blood vessels, act on the gastrin receptor to stimulate this gastric parietal cell, which secrete the HCl on the gastric lumen. Gastrin act on gastrin receptor, stimulate the HCl secretion. Also, the gastrin have receptors on the mast cell, stimulate the secretion of histamine, and histamine also that secreted from the mast cells as an autocoid, act on H2 receptors, tend to stimulate the HCl secretion, while the acetylcholine, which came from the cholinergic neurons, cholinergic nerve terminals, act on the M1 receptor, stimulate the HCl secretions. We have broglamide, as we mentioned, gastrin receptor antagonist, can inhibit the gastrin stimulated HCl secretion, while atropine and pyrinzabine, which can block this muscarinic receptor, can tend to inhibit this stimulated secretion through the cholinergic neurons, while the prostaglandins, prostaglandin E2 and prostaglandin I2, by acting on prostaglandin receptor, tend to inhibit the HCl secretion and also stimulate the mucus and bicarbonate secretion. We have a drug called misoprostol, which is an analog for the prostaglandin E2, can stimulate the prostaglandin receptors and tend to inhibit the HCl secretion. So it's a drug that used as a gastroprotective to decrease the HCl secretion in the patient that suffer with the peptic ulcer, especially that due to the chronic use of the non-steroidal anti-inflammatory drugs, because the non-steroidal anti-inflammatory drugs inhibit the formation of the prostaglandin E2 through inhibition of the cyclooxygenase, so inhibit the formation of the prostaglandins from arachidonic acid, AA, arachidonic acid, so decrease this cytoprotective mechanism that provided by the prostaglandin, so that the chronic use of the non-steroid anti-inflammatory drugs such as aspirin, ibuprofen, the mefenamic acid, and so on. These non-steroidal anti-inflammatory drugs can lead, its chronic use can lead to peptic ulcer because it decreases the protective mechanism that provided by the prostaglandins. We have the H2 antagonist such as ranitidine, cimetidine, famotidine can inhibit this receptor, so also this can lead to the decrease in the HCl secretion. Last, we have the proton pump inhibitors, PPI, proton pump inhibitors such as omeprazole, lansoprazole, rabeprazole, inhibit this hydrogen potassium ATPase, so they inhibit the terminal step in the HCl secretion. So these drugs are very effective to decrease HCl secretions. On the coming slide, inshallah, we'll come on in more details about these drugs. As we mentioned that locally produced prostaglandins stimulate secretion of both mucus and bicarbonate, and these mucus and bicarbonate tend to protect the gastric wall against the acidic pH and against the pepsin, the enzyme that can lead to breakdown or degradation in the gastric wall and can lead to ulceration. So these are considered as mucus and bicarbonate are considered as protective against these effects. So we will find that disturbance in this secretory and protective mechanism, الخلل في secretory and protective mechanism, are thought to be involved in the pathogenesis of the peptic ulcer. So that the peptic ulcer, which is an ulcer in a part of the digestive tract which is exposed to the gastric secretion, it is referred to either pepsin or HCl. Usually either from the over secretion of HCl or due to the direct contact of pepsin with the gastric wall. So this can lead to the ulceration. This is a peptic ulcer. The pathophysiology of the peptic ulcer, either due to the increased aggressive forces or factors. These aggressive forces or factors include the HCl, pepsin, and the Helicobacter pylori. The infection with the bacilli, Helicobacter pylori, as you know, this bacteria especially colonized on the acidic pH, and usually this environment occur in the stomach, low pH stomach. So this is considered as one of the pathophysiological mechanism by which peptic ulcer can be developed, or due to the decrease in the protective or defensive mechanism, which either the prostaglandin, as we mentioned, and mucus and the bicarbonate. These are the three protective mechanisms through which the gastric wall protects itself against these aggressive forces. The signs and symptoms of peptic ulcer include epigastric pain and tenderness, also anorexia, nausea and vomiting. Also hemorrhage can be occurred due to the ulceration. Now we'll talk about the pharmacology, the drugs that used in treatment of peptic ulcer and reflux esophagitis. Reflux esophagitis, the reverse or the reflux return of the gastric content through the esophagus. This can lead to the heart pain. The characteristic symptoms, the heart pain. The drugs that used for treatment of peptic ulcer and reflux esophagitis, we have the antacids, and also we have the H2 receptor antagonists and the proton pump inhibitors, and we'll talk finally about the treatment of Helicobacter pylori infection, as we know that it's one of the causative factors that can lead to the peptic ulcer. Also, we will talk about the drugs that can protect the gastric mucosa. First we have antacids وليس anti-acid. Antacids, and antacids, as we mentioned before, if you remember, act directly not through binding to protein molecules as most of drugs, but antacids act directly through neutralizing the acidic pH, through the neutralizing the acids that occur in the stomach. As you know, acid plus base reaction, this will lead to salt plus water, so this will decrease the acid contents on the stomach. Antacids, if given in enough quantity and for enough period, in a long enough period, this can produce healing of duodenal ulcer. Usually this can provide healing of duodenal ulcers, but less effective for gastric ulcers, because duodenal ulcer is easier to be treated because the duodenal pH is more than the gastric pH, which is less, so that as you know that the lower pH, the more acidic environment, so that the duodenal have less acidic environment compared with the stomach, as you know. Most antacids in a common use are salts of magnesium and aluminum. Magnesium salt, usually if used alone, can lead or can cause diarrhea, such as magnesium sulfate is known as a laxative agent. Magnesium salts can cause diarrhea, while aluminum salts can cause constipation. So in practice, we usually use a mixture of magnesium salt and aluminum salt. This to preserve or to serve the normal bowel function, not diarrhea and not constipation, the normal bowel function. We have also drugs that usually used in practice combined with these antacids, called simethicone. Simethicone is a surface active compound, antiflatulent, that prevent the foaming formation, that prevent the gases formation. And usually, as you know, flatulence can occur as the symptoms, one of the symptoms that occur with peptic ulcer and many other GIT problems. So simethicone is a surface active compound that sometimes combined with antacids, as I mentioned, to prevent foaming formation, to prevent gases formation. It acts by preventing foaming, so it can relieve bloating and flatulence. Now we'll talk about the H2 receptor antagonist. And H2 receptor antagonists are especially effective in healing of nocturnal acid secretion. This is because usually the nocturnal acid secretion depend largely on histamine, stimulated by histamine. So these drugs are very effective, especially in inhibiting the nocturnal acid secretion. They include cimetidine, had the famous name of Tagamet, brand name, Tagamet, trade name. Ranitidine is famous with Zantac, and nizatidine and famotidine. Side effects of an H2 antagonist are rare. This include diarrhea, dizziness, muscle pain, alopecia, loss of hair, and transient rashes, and hypergastриnemia. Hypergastриnemia, increased gastrin secretion on the blood. Also, this can occur as side effects due to the use of H2 receptor antagonist. Cimetidine inhibits binding of dihydrotestosterone to androgen receptors and increases serum prolactin levels. This results in famous adverse effects that associated with this drug اللي هو cimetidine. So when used on long-term basis or in high doses, it may cause gynecomastia in male and impotence in male and galactorrhea in women due to the increase of prolactin levels. These effects are specific خاصات فقط بيحصلوا فقط مع السايمتيدين and do not occur with other H2 antagonists such as famotidine or ranitidine or nizatidine. Also, cimetidine inhibits the cytochrome B450. It's known as a cytochrome B450 inhibitor. It is an enzyme inhibitor. So this can retard, prevent the metabolism of wide range of drugs and thus potentiate their action. This includes the oral anticoagulants such as the warfarin and the tricyclic antidepressant drugs. Now we'll talk about the proton pump inhibitors, one of the famous drugs that commonly used in practice. They irreversibly inhibit the hydrogen potassium ATPase as we mentioned, which is called the proton pump, which is on the terminal step. هم الخطوة الهيدروجين potassium ATPase is the terminal step. This pump terminal step that secrete الهيدروجين ion to bind with the chloride to form HCl in the gastric lumen. So this inhibition lead to decrease in both basal and stimulated gastric acid secretion, basal level and the stimulated gastric acid secretion. Both of these will be inhibited by the proton pump inhibitors. As we mentioned, this drug include omeprazole, esomeprazole, which is an S isomer for omeprazole. If you know, drug called Nexium is an S-omeprazole. omeprazole اللي هو اللوماك اللوكيد اوسيد lansoprazole, pantoprazole and rabeprazole. All of these are proton pump inhibitors. Proton pump inhibitors are extremely safe, so this lead or this يفسر لنا their common use in the practice. Uncommon side effects include headache, diarrhea, rashes, dizziness, insomnia, and mental confusion. Sometimes also impotence, gynecomastia, and pain in the muscle and joints. This can occur, but few adverse effects that associated with the proton or the use of the proton pump inhibitors. The proton pump inhibitors, PPI, should be used with caution in patient during pregnancy, also during lactation, and in patient with liver disease. The use of PPIs may mask the symptoms of gastric cancer because they decrease the symptoms or mask the symptoms, and the cancer will be developing, and this should be taken in consideration during the use or long use of these proton pump inhibitors. Last or before the last, we will talk about the treatment of Helicobacter pylori infection. And as you know from the pathology that H. pylori is the causative factor in the production of the gastric and duodenal ulcer, as well as a risk for gastric cancer. Colonization with H. pylori is the risk factor for development of the gastric cancer. So that eradication of H. pylori, eradication complete elimination, eradication of H. pylori infection, this will promote حفز induce rapid and long-term healing of the ulcer, and in the you will find that this is commonly routinely in the practice we test for this H. pylori in the patient that presenting with suggestive symptoms of peptic ulcer. So commonly routinely diagnostic test to test the presence of this H. pylori in the patient. If the patient positive with the H. pylori, so this patient should initiate a triple therapy. Triple therapy consists of 3 drugs to involve or to provide a complete eradication for this bacteria. The triple therapy usually contain a proton pump inhibitor اللي هو واحد من الدراجز بتاعتنا، اوميبرازول، لانسوبرازول، مانتوبرازول، رايبيبرازول، واحد منهم بروتون بامب انهبيتر. ليه؟ عشان ما يقلل اتش سي ال سكريشن، عشان ما يقلل الجاستريك اسيديتي. ليه؟ لانه الاتش بايلوري السوتبل انفايرمنت بتاعتها انها تعيش لي في وسط حمضي عالي الحمضيه، سترونج اسيديك environment. لما نقلل الاسيديك environment معناه نحن خلينا الانفايرمنت less suitable for the colonization of the H. pylori. Also, this should be combined with antibiotics to kill the bacteria, and this antibiotic we should use at least 2 antibiotics, either amoxicillin or amoxicillin and clarithromycin, and sometimes we use metronidazole instead of amoxicillin in case of the patient عندهم penicillin allergic أو هم allergic to البنسلين. نستخدم بدل الاموكسيسيلين ناخد ميترونيدازول اللي هو الفلاجيل. معناه triple therapy either consist of proton pump inhibitor omeprazole for example with amoxicillin and clarithromycin, and usually this prescribed for 1 week or sometimes for 2 weeks, usually in high doses, or metronidazole plus clarithromycin plus proton pump inhibitor, also this for 1 or 2 weeks to ensure complete eradication for the H. pylori. Last we'll talk about the drugs that used pharmacologically to protect the gastric mucosa. These drugs are called cytoprotective drugs. They enhance indigenous mucosal protection mechanism and or يعني معها أو provide a physical barrier over the surface of the ulcer, so protect the ulcer by a physical barrier. This include first we have the colloidal bismuth. The colloidal bismuth compounds such as the bismuth subsalicylate and bismuth dinitrate. These drugs have toxic effect on bacilli. They can kill the bacilli اللي هي ال H. pylori. Also they coat the ulcer. The ulcer base. Also, they stimulate the bicarbonate and mucus secretion, and as we know, the bicarbonate and mucus are cytoprotective mechanisms. So they tend to protect by this mechanism. All of these mechanisms tend to protect the gastric mucosa. The second drug that act as that act to protect the gastric mucosa, we have a drug called sucralfate. And sucralfate act by coating the ulcer. So by coating the ulcer, it inhibits the action of pepsin and HCl and stimulate the secretion of the mucus and bicarbonate. لما يعمل coat بيخلي يدي فرصة increase the secretion بتاع الميوكس والبيكربونات from the gastric mucosa. This is the sucralfate, which is an sulfated sugars. This will form the coat that protect the gastric mucosa. The third drug that protect the gastric mucosa, we have misoprostol, and we see previously that misoprostol is an analog for the prostaglandin, هو analog, stable analog for prostaglandin E1. It given orally and used to promote the healing of the ulcer and to prevent the gastric damage that may occur with chronic use of the non-steroidal anti-inflammatory drugs, as we mentioned, because the non-steroidal anti-inflammatory drugs, the chronic use will lead to the decrease of the formation of the cytoprotective prostaglandins، لأن النون-steroidal بتعمل inhibition للسايكلوكسيجينيز، الانزيم السايكلوكسيجينيز، واللي هو بصنع لي البروستاجلاندينز بصنعها من الاراشودينيك اسيد. فبالتالي هيقلل لي البروستاجلاندين اللي بتشتغل as cytoprotective. البروستاجلاندين دي ما هي كلها بين ميدياتر، احنا عارفين ان البروستاجلاندين هي ممكن تكون بين انفلاماتوري ميدياتر، عشان كده الناني ستيرويد بنديها as analgesic and anti-inflammatory، تقلل لي تعمل لي انالجيزيا بين ريليف وتعمل لي انتي انفلاماتوري افكت، لانها بتقلل من التصنيع بتاع البروستاجلاندين اللي بتشتغل از بين ميدياتر. لكن في نفس الوقت از سايد افكت هتقلل لي الفورميشن بتاع البروستاجلاندين اللي هي مفيده في انها تعمل لي سايتو بروتكشن، فبالتالي الكرونيك يوز بتاعها ممكن يعمل لي بيبتيك ألسر. فممكن ندي الميزوبروستول عشان ما يعوض لي، يحفز لي، يؤدي لي شغل الاكشن بتاع البروستاجلاندين اللي بتشتغل از سايتو بروتكتيف في الجاستريك ميوكوزا. اتس ابروفد، اللي هو نحن قاصدين الميزوبروستول هو ابروفد تم اعتماده for prevention of the non-steroid anti-inflammatory induced ulcer in high risk patient. However, it has never achieved a widespread use due its high side effects. لكن بالرغم من ده تم اعتماده، لكن ما عنده استخدام كثير منتشر في البراكتس، لانه هو مشهور بالادفيرس افكتس بتاعته، عنده a lot of adverse effects، من ضمنها انه يعمل لي نشوف، من ضمنها انه يعمل لي دياريا، يعمل لي abdominal pain، يعمل يوتراين كونتراكشن. واليوتراين كونتراكشن ده زيه زي الاذر بروستاجلاندينز، وممكن نستخدمه illegally for الابورشن، لانه يعمل لي كونتراكشن لليوترس سبيشالي في السكند ترايمستر، effective in termination بتاع البريجنسي، بالتالي can provide الابورشن so it can use illegally for to provide abortion. طيب. These are the side effects of misoprostol, and by this we finished the first part of the first lecture on the GIT. We talked mainly about the drugs that affect gastric acid secretion, and last the drugs that used to protect gastric mucosa. That is enough now. Inshallah, see you on the coming lecture that regarding, or we will continue on the pharmacology of the GIT. Assalamu alaikum wa rahmatullah wa barakatuh.